Hello everybody, this is Professor White, and today we're going to have a lecture about analgesic drugs. So these are drugs that are meant for pain control. Alright, so let's get started. The first thing we want to talk about is pain management, right? This is a very, very important aspect of nursing care, and one of the main reasons that people seek help from medical care. Pain is multifaceted. It affects all parts of a person's life. It can affect their ability to work, establish and maintain relationships. So anybody who's ever experienced pain, you know that sometimes it's all you can think about. So let's look at the actual definition of pain. It is an experience that is subjective, meaning that the patient is the one experiencing it. It is happening whenever the patient says it is, and exists whenever the patient says it exists. It is not up for debate. It doesn't matter if the patient's actions don't necessarily match what you think their pain response should be. Again, it's subjective. Just go right back to it. You should be assessing pain every time you're assessing vital signs with a patient. So they're now considering it the fifth vital sign. There's a bunch of different pain scales that you can use. One of the most common is the FACES scale that you see on here. It can help those who maybe don't have English as their first language. It also gives a numeric scale. And remember, a pain scale is just for us to quantify the subjective experience of the patient. Just because the patient gives us a pain number doesn't make it an objective assessment. It is still subjective. You know, there's a bunch of science that talks about how does pain develop and how does it happen and where does it go? But really, at the end of the day, pain is a result of the stimulation of these fibers called nociceptors. And those nociceptors transmit the pain signals from the various parts of the body to the spinal cord and up to the brain. So as we keep going, let's look at some other concepts that we need to be aware of. One is pain tolerance, right? So pain tolerance is the amount of pain that somebody can experience without it interrupting their normal function. All right, so this is a very, very individual experience, and it's the person's subjective response to the pain. So this is the reason why people with the same diagnosis can have varying levels of pain. This may be related to individual factors, person's attitude. It could be impacted by their culture, ethnicity, gender differences as well. So that's why I have a picture here of different people, all with pain, but their pain level is going to be different and their tolerance levels are going to be just as different as they are. Okay? So it's not a value judgment. It's just something to make sure that we're understanding about the subjective nature of pain. And then pain threshold is the amount of pain that's actually needed to create the perception of pain. And this is also different from everybody. So let's talk about managing people's pain, because that's really the name of the game here, isn't it? Pain management is highly individualized. We need to take into account the patient's values, attitudes, beliefs, cultural issues, ethnicity issues, everything that they're bringing to the table as far as how we can treat it. You also have to look at why the person is in pain. The cause of the pain will lead us down one road or another as far as pain control. If they have additional medical conditions, because that might limit our ability to do certain things. And no matter what, we need to continuously reassess what we're doing with our patients and go from there. So pain can fall under a couple of different categories. One category is if it's acute pain. So acute pain is pain that is of sudden onset. All right, you fall and you break your leg. That is an acute pain. Once you get that leg set and the swelling goes down, pain decreases. Now, chronic pain is persistent, recurrent. It lasts at least 3 to 6 months, can be very difficult to treat. And this is the type of pain that's often plagued by issues with tolerance and physical dependence. As we move on to the next slide, we'll look at the different types of pain that a person could experience. And these are very helpful in describing the pain. So somatic pain is arising from the skeletal muscles and the ligaments. Visceral from the organs and the smooth muscles. Superficial would be from the skin and mucous membranes, like you get a paper cut or maybe bite the inside of your mouth. Deep is considered below the skin. All right, so a lot of times people complain of deep visceral pain. Vascular is related to those pathological conditions that affect the vascular structures. So it might be pain related to poor perfusion or blockage. Referred pain is pain away from the actual origin. So for example, somebody with an abdominal issue, like let's say a giant cyst or something going on, might feel it up in their shoulder. That is a very common site of referred pain. Neuropathic is related to the nerves. Phantom pain is a special pain that occurs after a person has lost a part of their body, usually a limb, so it's often phantom limb pain, in which their brain is not processing the responses of pain that they're... Best way I can say it is that they still have pain from a limb that isn't there. So it's a neurological dysfunction part of it. Cancer is any pain that's related to cancer care. And central would be related to nervous system damage. So it's important to note the different types of pain because you may be asked to describe pain, or you can get some clarifying questions from your patients about what type of pain they're experiencing based on how they describe it. All right, so let's talk about this gate theory. This is a important concept to remember on why we are basically dealing with pain and how to stop the pain. So basically, this is the most common, it's a pretty well-described theory on how the person experiences pain. Basically, it's using the gate to tell us like if it's open or closed. So first things first is that there's going to be a tissue injury that releases lots of things like bradykinin, histamine, prostaglandins, and these stimulate the nerve endings and they start the pain process. And the nerve the nerve impulses enter the spinal cord, they travel up to the brain. And that point, the spinal cord is the gate. That's actually at the dorsal horn. This is a lot of anatomy and physiology. Basically, if the gate is open, the patient will feel pain. If the gate is closed, then the patient will feel relief of the pain. So what helps the body close the gate? So these endorphins and enkephalins. So remember what an endorphin means. An endorphin is an endogenous morphine, right? Morphine is a painkiller. It is an opioid. So the body does have receptors for opioids, and the body will fill those receptors itself with the endorphins. And that will close the gate. Some other things that can close the gate would be massage. Imagine if you banged your arm real hard and you have a pain sensation and you start rubbing it and it eases the pain, right? So that's using an additional sensory experience to sort of close that gate. And another thing that can help close the gate are analgesics. So these are our painkillers. These are the ones that can fall into different categories. They can be opioids and also non-opioids. Adjuvant drugs. So adjuvants, as you see on the next slide, these are not the primary pain relievers. Perhaps that might be your opioid, but these are medications we're adding to basically synergistically assist in the pain control. This might be your NSAIDs like Motrin, antidepressants. There's an old commercial where it said depression hurts, Cymbalta can help. So anticonvulsants, so that would be things like gabapentin and some of the others, and corticosteroids to reduce inflammation. So again, they're not working by themselves. They're working in conjunction. They are additive, so adjuvant drugs. The World Health Organization does use something called the 3-step ladder that we use to help us with the steps to pain control. So the first step is always non-opioids, right? So it can be with or without those adjuvant medications. Maybe it's a steroid and an NSAID together. If that's not helpful, then we go to opioids, with or without the non-opioids. So if that persists, then it's opioids for moderate to severe pain, with or without non-opioids. So we never just want to have a patient immediately start on opioid pain medication. So let's take a look at what are opioid drugs, right? So opioids are synthetic drugs. They bind to the opioid or opiate receptors. Some of the milder ones are codeine and hydrocodone. Strong ones, which is probably what we use the most in acute care, would be morphine, hydromorphone, or that's Dilaudid, oxycodone. Meperidine is not widely used anymore. Fentanyl is not as widely used in a hospital setting outside of operating room and some other special locations. And methadone. So remember, meperidine, it used to be more common. It's just not anymore. So just understand where it sits, but it's not something you would commonly be giving. Now, the mechanism of action for all of our opioid drugs, they could be agonist, right? So this means they're binding to the opioid receptors and blocking the pain sensation. Agonist, antagonist, so this is, they bind, but they're a little bit weaker. And then the antagonist, these are actually non-analgesics. These are not for pain control. This is what we're going to use to reverse the effects of opioids. So just look at those 3 different types of classes. So echoanalgesia, this is a very important thing to just kind of understand, is that different medications have different effects, and we compare those effects to morphine. So basically, it's the amount of a drug that we would have to give the same relief as that dose of morphine. So for example, this is just one of many different tables of such that says like PO codeine. You would have to give 100 milligrams of codeine to equal 5 milligrams of IV morphine. That tells you that that is not a very strong medication, as we learned before. Now, the other hand, hydromorphone, you would have to give 0.7 milligrams to equal 5 milligrams IV morphine control. That's pretty strong, but even stronger, look at the fentanyl. 0.05 milligrams to equal 5 milligrams IV morphine. So it just helps us make sort of considerations as far as dosing for patients. So why do we use opioids, right? Moderate to severe pain, often with those adjuvant drugs we talked about. And we also use them for other reasons, right? So cough center suppression, so people with coughs. Opioids to treat diarrhea. If we look at the side effect being constipation, this can make sense. And also for anesthesia, pain control during anesthesia. Several reasons a person should not have opioids. That would be, of course, a known drug allergy. Somebody with severe asthma because of the respiratory effects, and use it very cautiously, and all of those others that you see there. So increased intracranial pressure, people with morbid obesity, sleep apnea, people with paralytic ileus, because remember what opioids do to the gut. Pregnancy because of the results on the fetus, and also you can end up with a neonatal abstinence syndrome. The effects. There are multiple adverse effects to opioid medications. The chief among them is central nervous system depression and respiratory depression. That is deadly. Urinary retention, itching, nausea and vomiting, flushing, diaphoresis, miosis, which is the constricted pupils, and then constipation. So you can see my little infographic there. I have a person who's itching, a person who's tired, someone vomiting, and then somebody also about to do CPR. You need to contact the physician immediately if you have any changes in vital signs. Respiratory depression can be manifested by a respiratory rate less than 10 breaths a minute, dyspnea, diminished breath sounds, or shallow breathing. Some other topics to concern ourselves with would be opioid tolerance, and physical dependence. So this is not addiction, all right? Tolerance is basically when a person needs higher doses of the medication to receive the same level of pain control. And this is very common in our people with chronic pain and cancer pain, that they would require more analgesia. Physical dependence is the adaptation of the body to the actual drug in its system. So this is not psychological dependence, though people with psychological dependence also have generally physical dependence for many, many medications and drugs. Psychologic dependence, now this is compulsive drug use, and it's the craving for the opioid. So this is what we associate with the opioid epidemic. If a person were to stop the opioids, this is what might occur, right? We have the opioid abstinence syndrome. Basically, 6 to 12 hours after a short-acting opiate is stopped, person begins to have symptoms. 30 hours after long-acting, and then about 72 hours, so that's the approximate of 3 days, is the symptom peak, and that's where you end up with those very dramatic opioid withdrawals and severe cravings. Many interactions with medications, especially those that can also have a depressant effect on the central nervous system. So keep that in mind. Most of the opioid deaths that occur are because they are taking very strong opiates and mixing things into the system as well. Alcohol, benzos. Now we're going to talk about some of the drugs, and we won't spend too much time, just kind of go through them. You can definitely look at the slides and see what we've got here. So let's start with codeine. So codeine is considered Schedule 2, which means it's not as addictive, but it still does have an addictive effect. It doesn't work as well. It does have a ceiling effect, so it can only go so far for pain control. When you combine it with the acetaminophen, it becomes Schedule 3. So that is Tylenol with codeine. This is the one that's commonly given after dental procedures and also for coughs. Fentanyl. Fentanyl comes in many different forms. This is a Schedule 2 medication, very addictive. Parenteral injections, transdermal. So we have fentanyl duragesic patches. There's lozenges. There's all different ways that a person can get fentanyl. None of them are actually by mouth, though. So again, this is a very, very strong medication. This is generally prescribed for very acute use and in our patients who are potentially in the intensive care unit. Sometimes they're on fentanyl during surgeries as well. But other than that, it would be used for long-term chronic pain management, especially cancer pains and things like that. Fentanyl was prescribed actually for the, oh my gosh, I can't even think of his name, but he, it's gonna grind my gears here until I figure it out. Tom Petty. Tom Petty had fentanyl prescribed for him, which was implicated in his death. All right, so hydromorphone, this is the Dilaudid. This is one that there's a lot of jokes on the internet about, like the patients always want to come to the hospital because they want that med, the one that starts with a D. Honestly, the patients really do like Dilaudid for a couple of reasons, and it is available by mouth as well. So you may see this in the outpatient setting, especially with cancer care, is that it is an IV form generally. It can also be given sub-Q, IM, depending. But it is very potent. It works fast, so people do get pain relief from it. Again, respiratory depression would be a huge side effect of that one. Meperidine, when we do see it, it's usually used for migraines or for post-op shivering. So we'll move on from that. Now methadone's a very interesting drug. It has a very long half-life, which is very good for people with chronic pain because you can use less dosing, like dose it less often. But because of that and the effects of that, you can have more overdoses. Methadone is also what we give to help people come off of opioids as well. So like the whole methadone clinic, and if people are on maintenance therapy and to prevent problems during pregnancy for our opioid using patients. Morphine. So morphine is basically from the opioid poppy seeds. This is Schedule 2. It's meant for severe pain. And this also is available in different routes. A person would generally be placed on hydromorphone rather than morphine, but you might see morphine for different reasons, especially with allergies and some certain sensitivities. So this one being more, I guess you would say, natural. Its dosing is different. And again, this is the drug to which all other drugs are sort of compared. Oxycodone. This is a very commonly given opioid. It can be in an immediate release, which we call oxycodone, or it could be sustained release, like an OxyContin. Then we have some drugs that we have sort of mixed. We have agonists and antagonists. So these are considered Schedule 4. They're not, they're used for long-term pain management. And there are some that we also use for opioid dependence. Let's look at the next slide. So what happens if we have an overdose of those opioids? Well, two different drugs we have here. Narcan or naloxone, that's the one to treat acute opioid overdose. And naltrexone is not for acute overdose, that's to treat opioid dependence. So do not get them confused. Regardless of whether or not a patient shows withdrawal symptoms, if they are experiencing respiratory depression, Narcan should be given. Okay, so Narcan. Narcan is widely available. You'll see it in the hallways of the campus. It is available without a prescription. First responders are carrying this, and this is indicated in case of a suspected acute opioid overdose. So here you have it. If you suspect that somebody has an overdose, use the Narcan. If it doesn't work, then it's probably not an opioid overdose, but it will not harm the patient. Naltrexone, again, this is the by mouth. These are used for alcohol and opioid addiction. So this is an oral medication. Do not use this in cases of acute opioid overdose. It will not work. Now let's go into a little bit of the non-opioids. I think it's important to give a little nod to our friend acetaminophen, brand name Tylenol. This is often added to certain opioids, like Percocet would be oxycodone along with Tylenol or acetaminophen in it, but very commonly taken over the counter by patients as well. So works like the aspirin, so the salicylates. It inhibits prostaglandins. So because of that, it helps for mild to moderate pain, also antipyretic effects, and very good for those who can't take aspirin. Safety is a huge concern. Maximum daily dose is now being lowered to about 3 grams a day. those patients who are older or have liver disease down to 2 grams. There is the possibility to have an overdose on Tylenol. And if that can be very easy in the community. Imagine somebody is ill and they take 1,000 milligrams of Tylenol for the headache, and then they go over and they take a sinus preparation that also has Tylenol in it. So that is a very common thing that we have to teach our patients about, is to make sure they're looking at the ingredients of all over the counter so they're not inadvertently giving themselves too much acetaminophen. Some contraindications. So, of course, drug allergy. Anybody with liver dysfunction, you need to use it very judiciously. If somebody has signs of liver failure or something called G6PD deficiency, that is an inherited condition which affects the liver, and it causes hemolytic anemia when certain medications are taken, and among those might be this. So what happens if somebody has an overdose of Tylenol? So of course you want to stop it. Activated charcoal if it's within the first 4 hours. And then the antidote is called acetylcysteine. So it can be given IV for really severe cases, often given orally as well. And it's not just a single dose, it's like a combination of dates and times. Let me tell you about this drug. It smells awful. It tastes awful. It smells like rotten eggs. So if we're giving it to patients, it's often necessary to disguise the taste in something else, cola or, juice, and give it through a straw, right? Let them get it down, because it is a very smelly med. All right, we have a couple more to go through. Good old tramadol. So tramadol used to be non-narcotic. At this point, it's still non-narcotic. Used not to be scheduled. At this point, though, it is being treated as a bit more addictive because of the central activity of it. And so just be aware that that is out there. That's tramadol, commonly used in outpatient. Lidocaine. Lidocaine is a transdermal patch, is what we normally use, right? We have a 4% patch. But lidocaine can also be just rubbed into the skin as a gel. If we have a lidocaine patch, it's on for 12 hours, off for 12 hours because of the effect of the lidocaine. Apply any patches to appropriate decreased hair areas. That includes whether you're giving a fentanyl patch or a lidocaine patch or any other sort of transdermal patch. And then just a moment to talk about feverfew. So from the marigolds, it's a cute little flower, right? But it does have anti-inflammatory properties. People do use this for pain control. But it has many, many interacts with NSAIDs and anticoagulants. So I just wanted to draw your attention that your patient might be on this for pain control. So you'd want to make sure you do a very good assessment. So with all of these medications that we went through, remember the opioids, that they can cause severe respiratory depression, that they will cause constipation, they can cause balance issues. This is why it's so important to look at lifetime considerations as far as elderly and opioids. Even our older folks, they may not be able to metabolize them appropriately, leading to more effects from them. So that's going to end this lecture. It's about 30 minutes. Thanks for sticking with me. If you have any questions or concerns, please feel free to go ahead and pop them in the comments, send me a message. Have a great day.